question, if suppose it's a question in which you are supposed to be getting confused, like a clinical case, first read the question, understand the concept, and then find the clue words. So I used to say rook. Rook means first you have to read it, then understand the question, then you have to clear cut, you have to find the clues in that. So here we are supposed to see the clues as are all the secretions which would get more. And here there is a person who works in the field, that itself gives a good clue, which is a organophosphate poisoning, isn't it? So which answer is right here? Which answer is supposed to be right here? The first one, which is antidote that should decrease the parasympathetic action. Antidote that increases the parasympathetic action. Unknown substance that decreases the acetylcholine, and unknown substance that stimulates acetylcholinesterase. That is fine, that is there. And here the answer is antidote that decreases the parasympathetic action. And what is the antidote? What is the antidote? Yeah, that's very right. Anonymous, I could able to find the name as atropine. And the antidote here is atropine. Okay. So I want you to, why the question here, which is mentioning about organophosphate poisoning, is the reason because this question regards with your pharmacology also. Okay, I want you to see some points regarding the mnemonics, regarding a pharmacology view, to remember the mnemonics, right? Here, the mnemonic is sludge. So what does this mnemonic note? One is salivation, lacrimation, urination, diaphoresis, even sometimes GIT upset along with emesis will be there. All regards with your organophosphate poisoning. Organophosphate poisoning, and what it will do? It will decrease your PNS action, innervation, so that all the secretions would decrease. Once the secretion is decreased, then the physician would know that the antidote is working perfectly. Then other mnemonic which suits here is dumbbells. I hope you would have been read in your pharmacology, right? Dumbbells means D for diarrhea, U for urination, M meiosis, and bradycardia. And one more B belongs with your bronchoconstriction. As such, we are dealing with our parasympathetic nervous system. I hope you remember all the innovations of parasympathetic and sympathetic nervous system. All this comes under your picture. So I'm not going into much detail about what are all these mnemonic go through, but still a very simple overview of how the organophosphate poisoning looks and how do you give the antidote. That is important. That's what the nature of that question belongs with. The next question is, which of the following is right regarding increased lipolysis except? So what's the answer here? Option A, glucagon inhibition. B, increases plasma glucose level, decreases ketogenesis, and insulin stimulates it. So what do you prefer here as an answer? What can be the possibilities that here it could be the answer? So here we are speaking about increased lipolysis except, means we should think about decreased lipolysis, isn't it? So now can anyone think and say which answer suits here? Either glucagon inhibition or plasma glucose level which is getting increased, ketogenesis that is getting decreased, or insulin stimulation. This question relates with your biochemistry and your physiology as well. It relates with your both biochem and physio. If you have thoroughly read your part of amino acids and everything, then it will be easy for you. That's very nice. The answer is C here. It decreases ketogenesis. If you have understood the question easily, it's very simple. Means whenever see glucagon inhibition is there, for sure glucagon inhibits means if suppose the decreased function of glucagon, then the plasma glucose level will be decreased or increased. Glucagon's function is to increase your plasma glucose level. So obviously it would be decreased. But even though here we are speaking about lipolysis, we have to answer regarding with our lipolysis. So lipolysis is decreased in the sense plasma glucose will never be increased. And insulin stimulation will also never be the same. It is vice versa. Glucagon stimulates and insulin inhibits. Okay. So here one more thing you have to remember regarding your glucagon and insulin. See, regarding with your glucagon, what are all the process that is glucagon going to stimulate? Or it encourages the stimulation of, why not D? Because insulin stimulation means what happens when insulin stimulates? Can insulin stimulate lipolysis? Yes, of course, because glucose level would be lesser. But here we are speaking about decreased lipolysis. The question is vice versa. Here we are thinking about decreased lipolysis. Okay. Yeah. Yeah. In insulin stimulation, glucose level will be decreased. But in decreased lipolysis, first, your next mechanism of action will be ketogenesis that is going to be decreased. It's a question of vice versa. Even though if you have some doubts, we'll discuss in the end regarding the whole mechanism of action of how the lipolysis works. Okay. So in short note, glucagon stimulates your gluconeogenesis, right? All of the functions of increased glucose levels. Glucagon also stimulates your lipolysis, or it increases the lipolysis. It also increases your ketogenesis. Whenever your plasma glucose level gets increased because of any reason, all of the main mechanism gets increased. If suppose I'm saying plasma glucose level is getting decreased, then what happens? Then all the process would get decreased. Either it could be lipolysis, or it could be your ketogenesis, or it could be your gluconeogenesis. Matlab, it is vice versa where glucose level will be decreased. I hope it's clear, right? So apart from this, always remember glucagon and insulin will be inversely proportional. All of their functions are inversely proportional. Wherever glucagon stimulates something, insulin inhibits that. That is very important to remember, right? The next thing or the next question which we are going to see is, all of the following increases the prolactin levels except. So it is a very easy question. Dopamine agonist, dopamine antagonist, pregnancy, and phenothiazine. So it's a very easy question. Prolactin and dopamine is always opposite. Why phenothiazine? Why option D? What is phenothiazine actually? What is phenothiazine? Phenothiazine is it's a dopamine antagonist, right? So phenothiazine is a dopamine antagonist. So here the answer is dopamine agonist, right? So what happens whenever your prolactin levels are there? I hope in your notes it's very clear when it would be increased and when it would be decreased. So this is also important regarding your pharmacology and as well as your physiology. When it is getting increased in your pregnancy, in your lactation, right? In any kind of a stress related time, and in your dopamine antagonist. Dopamine antagonist. Yeah, even pregnancy and postpartum both relates the same. So dopamine antagonists, few drugs I want you people to remember. Not even if you can remember everything, at least remember something. Which is the first example will be haloperidol. All right, all of them have some side effects. The side effects of haloperidol, phenothiazine, risperidone, everything is important in pharmacological view. But as of now, the dopamine antagonists are haloperidol, risperidone, and your phenothiazine. Okay, so risperidone and phenothiazine. So these are very important dopamine antagonists, which you have to keep it in your mind at any cost. Even in your sleep, you should be very clear. Now coming to the decreased prolactin levels. So when the prolactin levels can be decreased, whenever there is a dopamine agonist. Dopamine agonists. A good example for dopamine agonist would be bromocriptine. Bromocriptine. And this one dopamine agonists or a dopamine action of any drugs would be a good prolactin inhibitor. I hope it's clear regarding this question. All of the following increases the prolactin level except the answer is dopamine agonist. Now coming to the next question, it's a bit different question, and also sometimes regarding the tract they might ask, because once or twice they have asked the function of the tracts. So hopefully this will also be the point which should be noted. Rubrospinal tracts are. So what is here the answer? It originates from the pontine reticular formation. It descends contralaterally. It controls activity of axial muscles, or it's a component of the medial motor. If you are very clear about your tracts, then it is very easy for you. So here the answer is it descends contralaterally. So very simple thing means the tracts which are descending and the tracts which are ascending. If you have been very clear about that, no in-depth or in detail knowledge about this should be there, because in-depth study of CNS or the nervous system will make you literally mad. So a very overview knowledge or a study about CNS will be easy for you. So the two tracts regarding the descending and ascending should be considered, and especially the tracts that is dorsal column and their functions, along with that anterolateral column, the tracts. These both are very, very important to remember. In that note, see the descending and the ascending tracts. How does it differ? Mainly the descending tracts are always a motor tracts, please remember. And the descending tracts, which is over here, which is sensory pathway, which is afferent in nature. So here, either please remember this side or else please remember that side. That would be better, at least to know the overview of what the tracts are. Coming to the point, pyramidal tracts, which is both anterior and the lateral corticospinal tracts, are a descending motor tracts. Okay. Now, if suppose the extrapyramidal tracts are there, they would involve in the other tracts, that is reticulo, rubrospinal, olivospinal, and vestibulospinal. Just remember the names, which is coming under extrapyramidal tracts. And if you see in the picture, it is running a contralateral manner, means in a contralaterally opposite manner, which comes along. So that is what there the answer is, which is contralateral. So coming this side of sensory ascending tracts, where the dorsal column tract, which we are going to see, that is important, and the anterolateral tracts, which we will see, that is also very, very important. Apart from this, if you know the spinocerebellar tract or don't know, that doesn't even make sense, but still you should be very sure in this note and very clear about your dorsal column and anterolateral spinothalamic tracts. See some important nucleus which you have to keep it in your mind. At least you have to know what they are and what their functions they'll do. First, seeing about the anterospinothalamic tract, they have a nucleus. This part I would not recommend you to remember. Even if you remember, that's well and good. If no, then that's fine. But this part is completely important because this shows your function. In anterior spinothalamic tract, they involve in crude touch sensation. Very important. They involve in crude touch sensation. In lateral spinothalamic tract, they will involve in your pain and temperature. They'll involve in your pain and temperature, which you know already. That is easy. That's fine. Coming into your ventral and dorsal spinocerebellar tract, please remember they both have very equal function, just they are differing from the nucleus. Once in a while, they have asked the name of the nucleus that is your marginal nucleus, are present in the which tracts? That is your ventral spinocerebellar tracts. So what is their function? They have a function of subconscious kinesthetic sensation, in which you will have a feel that someone is touching you, but subconsciously, not in a very clear manner. So that's what a subconscious anesthetic sensation. A spinotectal tract means it involves your visual reflex. Tectum always involves your visual reflex. Leave about the nucleus, but still the function of the nucleus is very, very important. Coming to the spino-olivary tract, that gives you a proprioception. This is also one of the important function to be remembered, a proprioception. Okay. Now, the next tract, spinoreticular, that is fine, that is gives consciousness and awareness here. In our corticospinal tract and in our spinothalamic tract, there are many differences, but these functions make some sense of having a differential nucleus and their differential function. In that note, please give importance to this a lot, that is your facial gracilis and facialis cuneatus. Gracilis will give you a involvement of proprioception, and remember cuneatus will have all of these functions like tactile sensation, tactile localization, tactile discrimination, and vibratory sensations. All this together will be a stereognosis sensation will also be involved. Hopefully this will be a quick review for you, a short review where the tracts, how they function. I hope it's clear. Now coming to the next question, a 41-year-old patient have a palpitations and dizziness for past 2 weeks, and he is a case of hypertension under medication. On examination, he is having a big swelling like appearance in between the back of shoulders near the neck. His arms and legs were too thin with poor wound healing history. So what is the suspected diagnosis? What is the suspected diagnosis? Any answers here? A, option A. Any other answers? So first what we have to do? First we have to read the question, understand the question, and get the clues. Yeah. Here we have read the question, understanding it a matter of just you understand that the case is having hypertension under medication, and he is having some symptoms like swelling like appearance, arms and legs, poor wound healing history is there. That is how we understand the question. And here the clue words regards with your case is a clue word. Big swelling appearance is a clue word. And he is having a poor wound healing history. Yes, that is very right. The answer here is Cushing's disease. Very, very right. Answer here is Cushing's disease. So how do you say here it is a Cushing disease? A very, very unique nature. That's a buffalo hump. Here the swelling says it as a buffalo hump. Very simple. So there is some differences between your increased cortisol levels or sometimes the decreased aldosterone levels, which sometimes get confuses you. Remember, in Addison's disease, there you will have a pathological problem in your adrenal glands along with the autoimmune diseases. But in your Cushing's disease, you will have a pituitary ACTH secreting tumor, which is secondary. So these two things you should remember in your mind. Apart from this, very few differences in your Addison's and Cushing disease that hopefully will help in your medicine part as well. Addison's and Cushing. Any important differences which differentiate between the both? Anyone? Anything that differentiates between the both? One, that which we have seen, one is your moon phase and your buffalo hump. That is to be remembered. That is also important. Apart from this, one is a kind of a decreased aldosterone. Yes, very, very right. Potassium level is also a very important term to remember whenever you come under diagnostic part. Potassium level is very important. It has decreased aldosterone also. They have decreased cortisol also. cortisol levels of the patient or a person will be decreased for the diagnosis under Addison's disease. Here, one and only your increased cortisol levels will be there. Right. Sometimes here the patient have a history of hemorrhage. Hemorrhage. Sometimes the patient will have a history of hemorrhage here. Sometimes the patient will say, or else he have a history of trauma as well. This will be a clue word for you. But here in Cushing's disease, any source or any kind of a pituitary problem, any kind of a pituitary gland issues will be a clue for you. Will be a clue for you. That's fine. Coming to the important nature, here would be your electrolyte and the metabolical imbalances. Always remember, the patient here will be always hypotensive in nature. As such, here our cause would be hemorrhage and trauma. And here the patient would be hypertensive in nature. In males, here they'll have an impotence and menstrual changes in females, which is a very indominant feature, but males' impotence would be very keenly notified. And hirsutism is also an important symptom to be remembered. And when we are speaking about the potassium changes, and sometimes if I say even the calcium electrolyte changes will also differ, here everything will be higher rate. Means we'll have a hyperkalemia, hypercalcemia, and here everything would decrease. That is hypokalemia and hypocalcemia. Remember, you have a bronze skin in your Addison disease. One important skin pigmentation and skin differences which is unique to be notified in Addison's disease. Here, striae will be red, which is very right, said by some other persons. That is striae of reddish purple in color, which is also an important systemic manifestation, which is reddish purple in nature. The reason I'm writing it down all the way is it is important in your medicine point of view. Especially you can see these striae. Where you can see these striae? One in your abdomen and in your upper thighs. So these are the specific sites where you can see these striae, which is reddish purple in color. All right. So these are the very important significant feature which differentiates your Addison's disease and Cushing's disease. Yes. And if I say about sodium, here sodium is also one of the electrolyte which is to be mentioned. Speaking about sodium, here in Addison's disease, you will have hyponatremia. Remember, you will have hyponatremia. And along with your glucose level also will be increased, hypoglycemia. Please remember all these important clinical and the laboratory diagnostic features. Here everything will be increased. Sodium and your glucose levels. I hope it's clear regarding your Addison's and the Cushing's disease. So now coming to the next question. In which of the following areas is a type of neuron which is present? Actually, here the picture would be depicting your, what is the picture showing? What is the picture supposed to show? Yes, here actually in the picture is supposed to show your pseudo unipolar neuron. So I would say this picture only one, it should be given. It is not actually included in the question. Only first picture, your pseudo unipolar neuron. The very fine example would be your dorsal root ganglia. Dorsal root ganglia. Right. So same like this, you have to remember if the neuron, there is a single process, if the neuron has two processes, if the neuron has many processes. I do believe that there is one more question that regards with your multiple processes also, right? So see, if suppose a unipolar neuron with a single process is given. What is a very fine example here? The neurons which is seen in invertebrates are an example for unipolar neurons. Unipolar neurons. Coming to the bipolar neurons, which is having two processes, one and below other. Your retina means retina, eyes, which is two, remember like that. Then the example here would be retinal bipolar neurons. Okay. In your pseudo, remember pseudo is having so dorsal root ganglia of neurons comes under pseudo unipolar neuron. Coming to the multipolar neurons, multipolar in the sense many processes will be there. For multiple or a multipolar neuron, remember P's, especially the P's are more dominant letter here. Why? Because they have a Purkinje cell. They have a Purkinje cell. They have a pyramidal cells. They have a pyramidal cells. And especially the pyramidal cells of hippocampus. And also your motor neurons of spinal cords. Motor neurons of spinal cord. So especially these Purkinje cells, where do they present actually? Any idea? Purkinje cells are present in? Purkinje cells are present in? Then Purkinje fibers are present in? Yeah, that's very right. They are in your cerebellum. They are cerebellar cells. Cerebellum have 5 cells, and regarding in the layers of 5, the one will be your Purkinje cells. The cerebellar Purkinje cells are example for multipolar neuron. Very simple question. And the next question here regarding your EPO, that is your erythropoietin. Regarding erythropoietin, which of the following is right? It acts to increase the RBC by cell division. It's principally inactivated by the spleen. It is produced by the adrenal gland, or its production is inhibited by theophylline. So which is the right answer? Do you actually think erythropoietin is produced by adrenal gland? The reason I'm asking is most of the people are giving answer of production by adrenal glands. Why? Why so? Yeah, where this erythropoietin comes from? I hope in your general physiology and blood physiology, this topic is easily covered. Where is the source of erythropoietin? I can understand and I can able to see some students are supposed to give an answer of A. Actually, if the question is like this, sorry, if the answer is like this, it acts to increase RBC, then I'll agree with you. The option would be A. But here the answer is like this. It acts to increase RBC by cell division. Do you think so? Erythropoietin have an action of increasing RBC by cell division. Yeah, if your pharmacology is a bit, if you have been knowing about that a bit, and you read about theophylline, always theophylline have inhibitory property of erythropoietin. Very, very important. Okay. Main thing about theophylline to remember, see, whenever you have erythropoietin property, we know that it increases or it gets stimulates during your hypoxia, right? It stimulates in your hypoxia. But a very important drug which is given in your shortness of breath and breathing difficulties, that is your theophylline. So what is the drugs that means what? Which is a group of drugs? Theophylline is coming under theophylline. Yeah, it's an asthmatic medication. That is fine. I agree with you. Yes, PD4 phosphodiesterase inhibitors, right? It's an asthmatic medication, and even in a shortness of breath bronchodilators, we have give it as well. In a bronchoconstriction condition, we are going to prescribe this theophylline matter. Then you can ask me why this, especially the drug which comes under theophylline, a PD4 inhibitor, is inhibiting the EPO just because it acts in hypoxia. When you give this kind of a bronchodilator, this is one of the important side effects. It makes or it inhibits the production or the activation of erythropoietin whenever it gets stimulated in hypoxia if the patient is in bronchoconstriction condition. Okay, so this is a kind of a exceptional question where you can rule out the answers. So it's an example how you can rule out the answers by a manner which you know or a notes which you know already. See, you know already that erythropoietin is produced by your kidney, right? And liver. So mainly 85 to 90 percentage by your kidneys, and liver just constitutes about 10 to 15 percentage. 10 to 15 percentage. The main thing, always remember, hypoxia means erythropoietin will always be stimulated or it increases in your hypoxic condition. Okay. And whenever there is an involvement of your anterior pituitary hormonic condition, there is a possibility that erythropoietin levels get increased, such as your growth hormone, even sometimes your prolactin, your follicle stimulating hormone, and your ACTH as well. So they also increases your erythropoietin production of conditions. I could able to say in high altitude. Hypoxia literally means in high altitude. Even I'm mentioning here that high altitude also makes sense. So there is another note where it will be decreased actually. So in a renal patients, in a renal failure patients, decreased erythropoietin or the level of erythropoietin will be decreased or the production will be less. Or the production will be less. And sometimes a patient with liver diseases, or I could say CKD patients, yeah, CLD patients, very right. A patient or a female who is having more estrogen levels, or else sometimes the females who are anemic. The reason of letting you note down all these points just to make you clear that these are the conditions where you could see the decrease and increased production of erythropoietin. Right. Coming to the next question. A 8-year-old boy frequently comes to the clinic for persistent skin infection, which is a clue, that do not heal within a normal time frame. He had a normal recovery from the measles. It's a history. This is also a clue. Check of his antibodies after immunization yielded normal antibody response. A defect in which of the following cells would likely be the cause? We are asking, the question here says about persistent skin infections. It's a direct question. It's just a clinical case question. If you know about the general view of the cells, about the blood physio, then it is very easy. Defect in which of the cells would cause persistent infection? A literally direct question. They are asking about the persistent skin infection. Right? So here the options are B lymphocytes, plasma cells, neutrophils, and macrophages. And here the boy is having a history of recovery from measles. Recovery from measles. So what will be or what would be the answer here? After immunization, his antibody responses are normal, and they are asking about the cells which is deficient. Cells which are deficient. Here the options say, some of them say, some of you say plasma cells, some of you are going with lymphocytes, and some of you are going with neutrophils. So which would be the right answer? See, always persistent infection will be a very, very unique nature of, or I could say this is a very unique nature which doesn't even goes with any of the cells. Answer here is neutrophils. If they mention some simply a skin infection, then it would be a separate scenario. You could get confused. But here, literally, the question says persistent skin infections. Persistent skin infections. So the direct answer here is neutrophilia. Neutrophilia. So what are all the conditions you can see neutrophilia, or when the neutrophils production would be decreased, or what is the main scenario or these kind of an infection which would you feel when neutrophilia is there? Any other important unique feature of neutrophilia? Any other neutrophil disorder diseases do you know? Yeah, it's neutropenia, neutrophilia. Yeah, weaker immune system, autoimmune condition of all the infants, autoimmune conditions of all the infants comes under neutropenia. Then a very important syndrome, that is Chidiac-Higashi syndrome. Chidiac-Higashi syndrome is also in neutropenia, right? And sometimes I could say a glycogen storage disease, a main glycogen storage disease sometimes comes under your neutropenia. Mainly not skin infections, especially persistent skin infections literally deals with your neutropenia. And any kind of a chronic inflammatory diseases, or I could say a chronic infectious diseases. So these are the few lists which would say neutropenia under condition. Okay, so here it could be drug induced also, possibilities that it could be drug induced also, or it could be idiopathic also. The lists of this neutropenia comes under any of the autoimmune diseases. Either it could be drug induced or it could be idiopathic. Now coming to the next question. If you drink a liter of water very quickly, the result would be. If you drink a water very quickly, what is the result? So option A, oxytocin increase, ADH increase, oxytocin decrease, ADH decrease. So what is the answer here? If you drink a liter of water very quickly, what is the result? Here they are saying about oxytocin and ADH. If you know clearly about the all functions of oxytocin and ADH, it will be easy for you to remember what is the answer here, right? So what about the important ADH secretions that you have to know? Here the answer is ADH secretion, that is decrease. ADH secretion, that is decrease. Why? See, if you see about ADH means uses or else the functions of ADH, what would be your answer? We have seen many of the ADH functions. When we'll have the antidiuretic hormone function of increase in level, and when we would have the antidiuretic hormone function of decreasing levels. Any idea when it would get increase and decrease in a very specific place? Yes, in insipidus. See, whenever you have increased fluid intake, The increased fluid intake will make your ADH level to be, or the action of ADH secretion to be decreased. Okay, increased fluid intake will cause their ADH secretion to be decreased. Why so? The main function of ADH secretion is to absorption of, what is the main two function of ADH? Main two function of ADH is H2O reabsorption, isn't it? Main function of ADH is H2O reabsorption, especially by your aquaporin 2 channels. And here, if we have already too much of fluid intake, why the secretion will be more? So the obviously antidiuretic hormone secretion will be less, so that it will be easy for your reabsorption levels to get lower, and there will be too much of urine output will be there. So if there is a decreased fluid intake, then obviously the secretion will be higher for absorption of your water to maintain your fluid level. Maintain your fluid level. So this is the condition where it could increase or decrease. Okay, so that we can say they are increasing your absorption. Yes, hypotonic urine. If the absorption is increased, then you will have a hypertonicity. And this concentration of urine is always depends upon, the concentration of urine always depends upon your ADH. But please remember the absorption, the reabsorption or the maximum reabsorption in your renal part will be in, rather than depending upon ADH, will be in, the maximum concentration of reabsorption without depending upon your ADH will be in PCT, always proximal tubule will be your maximum concentration of reabsorption without depending on ADH. But regarding your concentration of urine, ADH is important. The other conditions where your secretion of ADH is increased and it is decreased in your hypovolemia, that I had said already, which is in decreased fluid intake. In other means, it is hypovolemia. Even sometimes because of dehydration or because of any means the fluid intake is decreased, then in that condition you will have increased production of ADH. And sometimes, why not late DCT? Always the reabsorption will be in maximum in your proximal convoluted tubule. Because if you see, exceptions are very few, like your magnesium, right? And your amino acids. Glucose is having a zero reabsorption, in which PCT is having a very few electrolytes that is being reabsorbed. Nevertheless, regarding your ADH. Because in late DCT and in your collecting duct, you will have a concentration of urine property, but never a reabsorption process which is dominant. Always the reabsorption process will be dominant in your PCT. And increased fluid intake also regards with your alcohol. Alcohol intake is also included in your part of ADH secretion that is to be decreased. Okay, so I hope it's clear. Coming to the next question. All of the following have one axon and many dendrites, except this also have been explained for you. And here the answer is, this comes under multipolar neuron, right? Multipolar neuron means there is one axon, there is many dendrites, that comes under multipolar neuron. And here the answer is, here it's an exception case. What is the answer? Here the answer is D, that is invertebrates, because it comes in your unipolar neurons, which we have discussed. That's right. Yeah. Next question is the structure between the circular and the longitudinal smooth muscle layer. Structure between your longitudinal and the circular smooth muscle layer. That is your Mason's plexus, your submucous plexus, your sensory function, and your myenteric plexus. What would be the answer here? What about the plexus here mentioned? What is the structure that is between actually your circular and the longitudinal smooth muscle layer? I could able to see multiple answers. There are actually, we have many plexus which is included in your GIT, right? In your gastrointestinal tract. Apart from this, the main classification of all the structures in between your structural, circular, and the longitudinal that involves, see, in your GIT part, mainly the plexus that is involved and the structure which you have to remember is the innervation, right? One is the part of extrinsic and another one is your intrinsic. I hope you already know the mnemonic of MAM and maze, isn't it? Your MAM obviously is your myenteric plexus. Here is your Auerbach's plexus. And you have a motor function. And in your maze, you have Mason's plexus, submucosal, and your sensory function. And your sensory function. If you see here, this will be in your circular and longitudinal layer. So here the answer is myenteric plexus D. And see, in your intrinsic innervation, always remember they will be between your submucosa and the circular layer. Please remember this always. And in the extrinsic innervation, especially the intrinsic innervation, you will have this both. In the extrinsic innervation, you will have the parasympathetic and the sympathetic innervations. I hope you're clear about that. In your parasympathetic innervation, all the secretions are increased, and your sympathetic innervation, all the secretions are decreased. Okay. All of the tone, motility, peristaltic, all the secretory functions are decreased in your sympathetic nature. And one more important thing to be remembered in your sympathetic and parasympathetic is the sphincters. They are closed in your sympathetic, and in your parasympathetic part, they are relaxed. This is also important. Next thing, the next question. This is also a direct, easy question. Myasthenia gravis is due to. The antibodies against nicotinic cholinergic NM receptors, or the nicotinic NN receptors, or the muscarinic receptors, or the voltage gated sodium channels. Yeah, everyone should be right here. The answer is antibodies against nicotinic cholinergic NM receptors. Very, very important. See, already I would have been seeing many part about myasthenia gravis. But on the whole, you should be very clear about the both myasthenia gravis and Lambert-Eaton syndrome. Myasthenia gravis and Lambert-Eaton syndrome. So what is the main difference between both myasthenia gravis and Lambert-Eaton syndrome? The very important difference in their antibodies, which is producing against within them, that you have to remember for sure is, here it's an autoimmune disease. Yeah, that's very right. It's literally goes on with Lambert-Eaton syndrome. And in the rest-taking condition, also it is getting differed. Who is going to take rest a lot and who is going to be in an active condition? Myasthenia gravis people will be good at rest. And the person or a patient who is having Lambert-Eaton syndrome will be good with activity. just because of the difference in their channels. Just because of the difference in their channels. And please remember, the myasthenia gravis patient will be having diplopia, drooping of eyelids. Drooping of eyelids also. All right. These are the very important point to remember. And the sudden rapid onset of fatigue will also be there in your myasthenia gravis. Remember as fatigue. They'll get tired easily. They'll be tired easily. The next question is the best moving touch receptors are present in. The best moving touch receptors are present in. Where is the best moving touch receptor? Paucinian corpuscles, Meissner's corpuscles, Merkel's disc, and the Ruffini's end. The best moving touch receptor. There are many moving touch receptor, but which one would be the best? There is much confusion between B, C, right? So, which is right regarding your best moving touch receptor? Many having confusion between your Meissner's corpuscle and Merkel's disc, isn't it? Meissner's corpuscles and Merkel's disc. So how does it differ? Either it's a best moving touch or best moving vibration. Who is under best moving touch and who is under best moving vibration? Which receptor is going to differ in that? See, always remember, moving touch receptor, here the answer is Merkel's disc. Okay, here the answer is Merkel's disc. When we are speaking about vibration, then the answer goes on. When we are speaking about vibration, then the answer goes on. If you're speaking about vibration, please remember here the answer goes on with your Meissner's corpuscle or sometimes your Paucinian's corpuscle, which is most sensitive. Even in the less hertz, we can able to hear that. But more than that, nowadays we would prefer Meissner's corpuscle for vibration because in very low vibration of which is equal to 50 hertz, you can able to feel the sensation by the Meissner's corpuscle. If we say that largest touch receptors are Paucinian's corpuscle, we say that largest touch receptor are Paucinian corpuscle, but the most sensitive, what is the answer if it is the most sensitive? Most sensitive, the best stimulus would be your Paucinian's corpuscle, okay? There, how the Paucinian and the Meissner's corpuscle would get differ by their vibration. By their vibration. One second. Yes, by their vibration, see, Paucinian corpuscle will have vibration of around 200 hertz. That is how they get differ. 200 hertz, Meissner's corpuscle of around even in the low vibration of 50 hertz. And which is most sensitive? The most sensitive touch receptor is your Paucinian's corpuscle. And apart from this, you have a most numerous receptor. Which is the most numerous receptor? That is your Meissner's corpuscle. There is one more question. The blind persons who supposed to use a Braille system, which is a very fine touch. Which touch receptor is used in this Braille system? Anyone knows? Which receptor is used in this Braille system? Yeah, Meckel's disc more than your Meissner's corpuscles. Meckel's disc more than your Meissner's corpuscle. Very important. Once in a while they have asked in the Braille system which receptor is used. And the 2-point discrimination is felt by which of the receptor? 2-point discrimination is felt by Merkel's disc. Most of the question goes on with your Merkel's disc. Okay. The point, the pin touch will be your Merkel's disc. Please remember, all are at your dermis part, all of the receptors. All of your touch receptors, vibration, all of the sensation of your receptors are at the level of dermis, except one of the receptor, which is that exceptional case. Except the one touch receptor, all of the touch receptors are at the dermis level, which is that one case. Please remember that's your Merkel's disc. Very right, that is in your epidermis. That is in your epidermis. When you have a stretch on a skin, then it comes under Ruffini's ending. The stretch on a skin is easily felt by Ruffini's ending. A tickle or a itching feel. Who can give a tickle or a itching feel? The tickle or a itching sensation is given by your free nerve endings. Free nerve endings. Remember, these are the few very important points and the important questions which have been asked repeatedly, which I have compiled in as of once. Yeah, very important. And why the answer of Merkel's disc comes again and again, because it's a slow adapting touch receptor. One of the important receptor which is rapidly adapting and which is largest as well, that is your Pavlinian corpuscle. And that comes under general touch is your hair and organ. Hair and organ is in your general touch. Hair and organ is in your general touch. Right. If I speak about the corner touch, for example, you can touch your mobile or you can touch your remotes, and you can able to say it is a mobile, it is a remote, or it's a paper, it's a book. It's because of your corners or edges or a point. Always it goes on with your Merkel's disc again. Merkel's disc again. The question can be asked at any manner, but the answer is the same, that is your Merkel's disc. The final and the important question, maximum touch receptors are seen in. The maximum receptors are seen in your all over the body. Where can you see your maximum receptors? Maximum receptors are seen in. Any ideas? Yeah, that's right. Skin, in the sense, we have all over the body, we have skin. Any specific part where you can see a maximum receptors, a tactile receptors, either it could be rapidly adapting or it could be slowly adapting. Please remember, your maximum receptors are seen in tip of the fingers. Tip of the fingers more than your lips. Yeah, tip of your fingers more than your lips, where you can able to see all the tactile receptors, which is a maximum in nature. All the adaptations are being given in your persistency of the adapting stimulus. So I hope the full part of the touch receptors is clear for you. Now, the next question is, the following statement is correct regarding the image that is shown below. What is the image which is actually shown here? And what is the statement that is right? They have a long and fast waves, which is seen everywhere where except esophagus, which is decreased by acetylcholine and increased by epinephrine. What is the picture actually shown in the given image? What is this? Here, it is actually an excitation contraction couple in the gut they have given. But what does this wave says? The waves actually, it's a basic electrical rhythm, which is the so-called BER. Okay, this is a basic electrical rhythm. These are one of the important function in your excitation contraction coupling. The main BER, this rhythm is seen everywhere and especially they are slow. They are slow. Even by seeing the waves, you can see that they are slow. The waves are slow waves and they are initiated by the important pacemaker cells in your stomach, that is your interstitial cells of Kajal. Interstitial cells of Kajal. And one more thing, they are increased by these rhythm, especially the spikes in the rhythm. I hope you can able to see the muscle tone and the membrane potential spikes. These are increased by acetylcholine and they are decreased by epinephrine. Means they are stimulated by your PNS and inhibited by your sympathetic system. Can you predict the answer now? The following statement is correct regarding the image shown below. So what would be the most possible answer here? I said it is a slow waves. I said it is decreased by epinephrine. Yeah, it's seen everywhere except esophagus. Very important. You cannot see any kind of a basic electrical rhythm, or I can say a MMC complex. What is MMC? It's a, what is MMC complex? In your GIT physiology, you would have been done. It's a migrating motor complex. It's a migrating motor complex that is seen in all of your GIT gut, especially from the stomach. Yes, very right. Because of motilin, you have this MMC process. Stomach to the distal ileum, you have this migrating motor complex. They are a very slow waves. The spikes all have been seen, especially near the myenteric plexus. You can see all this kind of a rhythm. Without these rhythm, your peristalsis is not actually possible. Your peristalsis is because of this migratory motor complex and the basic electrical rhythm. And the exception of this BER, basic electrical rhythm, are one we have seen, you cannot see in esophagus. And the next exception is you cannot see in proximal part of stomach as well. You cannot see this rhythm in proximal part of stomach as well. Very important. So that is how they are unique in their nature. It is same like the excitation contraction coupling in your skeletal muscle. But in the gut, there is an exception. One and only, they cannot seen in your esophagus and they cannot be seen in proximal portion of stomach. Right. The next question, the neurotransmitter that carries pain signals, which is a mediator of inflammation. The very direct question, which is in C fibers. So what is the answer here? The answer here is, yeah, very right. That is substance P. So if suppose I'm saying here the question as A fiber, then what is the answer? If I'm saying there is an A fiber, then what would be the answer? Then what would be the answer here? Yes, then the answer is your glutamate. See, always remember in C fibers, the pain sensation are always carried by your substance P. A very direct one-word question, glutamate. Just because it was given mediator of inflammation, please don't give an answer of histamine. If A fibers are given, glutamate are a direct answer for this pain sensation. For this pain sensation. I hope you got it. Next question, the distension of the stomach happens in which phase? It's also a very direct question from your notes. The distension of the stomach happens in which phase? Cephalic, gastric, intestinal phase. Yeah, it happens in your gastric phase. It happens in your gastric phase. Very important note in your cephalic phase, which I would like to mention here is, please remember always in your cephalic phase, what you have to remember, gastric phase, what you have to remember, and in the intestinal phase, what you have to remember. Please remember first the percentage, which is most important and most dominant, which is a gastric phase, 20%, and the 10%, which is in your intestinal phase. I hope you remember vagus nerve is important in your cephalic phase, but I'm going to give an importance for the psychic stimuli. Psychological stimulus are playing a main role in your cephalic phase. In your gastric phase, the name itself says we have a gastric secretion, and the distension plays a very great role. Distension plays a very great role. Now, in intestinal phase, the very one more thing, all the reflexes responses are given in this intestinal phase. So, very important clue words. Even if you remember the percentage and these clue words, that is perfectly fine. No issues. No need to go in detail. The distension mainly is involved in your gastric phase. Next question. A boy who had to have his amputated arm at the elbow after an accident. He tells that he can sometimes feel the pain in his fingers even though the hands are amputated. What will be the cause of his pain? I can understand this question is a bit confusing question, but still, nerve stimulation, formation of neuromas, impulse generated from the nerves. It's his assumption of having pain. So what will be the answer here? So most of you are going with an answer of impulse generated from the nerves, right? So the answer here actually, any ideas, any other different answers I could accept? It's his assumption of having pain. That's great. Actually, it's not his assumption of having pain. Yeah, yes, very right. Some of you people are giving a very right answer. That's formation of neuromas. It's the formation of neuromas. It's a phantom pain. That's right. It's a phantom pain. It is because of a formation of neuromas. But how? And how? See, always remember, if the patient or a person is having amputated hands, if the patient or the person is having an amputated hands, the end of the nerves are cut. We know that the end of the nerves are cut. So how can they impulse degeneration? Is it possible that there is a spontaneous, we can say that spontaneous discharge is there. It doesn't mean that there is an impulse generation is there. Okay, spontaneous discharge, electric discharge will be there, and there is spontaneous pressure will be there. Spontaneous pressure will be there. The impulse are generated not from the nerves, but from the previously innervated nerves. This is an important turning point or the twist over here in the question. The impulse are generated from the previously innervated nerves, not from the at present nerves, which is giving innervation to the rest of the arms. Right? The sensation of this pain is given by the sensal organ of the amputated limb. Just because all of their organs are sensible, once the organ is amputated, for example, this is amputated, till here you will have that sense. The sense is giving a pain, but all these happens at the time of amputation. You will have a neuroma formation. At the time of amputation, you will have a neuroma formation. So, at the time of amputation, whenever there is a discharge, you will have a neuroma formation. You will have a impulse generation, but not from the present innervated nerve, but from the previously innervated nerve. He is having pain. It doesn't mean he is having an assumption of pain. Nerve stimulation is there, but it is also from the place where the sensible organ which is innervated. So the perfect answer here is the formation of neuroma that gives the pain to the person, and that is the reason why he feels the pain. Okay. So I hope it's clear. The next question is, this law states that, even though this is a question from your CVS, but still I have given this question because it's a repeated question of this law which is being asked multiple times. What is the law that it states over here comparing to the image which is given? What is the law here? Increased heart rate leads to increased cardiac output. Increased discharge leads to increased cardiac output. Increased venous return leads to increased cardiac output. Or increased blood pressure leads to increased cardiac output. Here in the graph, in the picture, they show that decreased venous return also, increased venous return also. How does it matters relates with this law? And what's the name of this law? This last roots with some name, and they have some explanation within them. If anyone does know the name, please mention in the chat box. This chart actually means whenever the venous return decreases, all of your stroke volume, all of your ejection fraction, all of your end diastolic volume, and everything depends upon your venous return, isn't it? If that is decreased, each of them will be decreased. Very, very right. It's a Frank-Starling's law. Venous return will be decreased, then they will affect all of your stroke volume, ejection fraction, and end diastolic volume. When the venous return is decreased, the pressure or the volume of the blood which comes in your all of the chambers, especially in the atria, that gives your stroke volume, and the leftover blood in your ventricle filling gives the end diastolic volume also will be decreased. This law actually states Frank-Starling's law. Frank-Starling's law. If any of the stretch receptors, if suppose in your heart is stimulated, so this stretch given in your heart is going to increase your venous return. PR is your venous return. So whenever venous return increases, your cardiac output increases. Whenever your cardiac output increases, they are going to involve with your stroke volume, involve with your ejection fraction, and involve with your end diastolic volume. That is for sure. So here the Frank-Starling's law states venous return increases, that obviously going to increase your cardiac output. So here the answer is increased venous return leads to increased cardiac output. The stroke volume and the ejection fractions here literally shows about your cardiac output. That is how the chart depicts. Any doubt? Next question. The levels that is decreased in your Graves' disease. Which of these levels is decreased in your Graves' disease? Which of these levels are decreased in your Graves' disease? Your T4, TSH, diiodotyrosine, triiodothyronine. Yeah, it's a direct answer. In Graves' disease, you will have a decreased TSH just because your T3 and T4 are more. Okay, so this is literally your thyroid stimulating hormone that gives Graves' disease. This is actually an autoimmune disease, right? This is actually an autoimmune disease. Either the TSH be decreased or the gland size will be increased. There in the autoimmune disease, they form an antibody against LATs and TSI. I hope you know what about LATs and TSI. It's long-acting thyroid stimulators and the thyroid stimulating immunoglobulins. All right. As such, your T3, T4 levels are increased. It's the most important cause of and the most common cause of hypothyroidism. Very, very important. Yes, very right. And it's in your hypersensitivity reaction as well. But sometimes when the TSH levels get deranged, it comes in your autoimmune part of your type 2. Okay. So it's a direct answer, thyroid stimulating hormone. The next question, a 37-year-old woman presents to her physician with an enlarged thyroid gland and the plasma levels of T4 and T3. Here, I hope the decrease in level they would have been given. And which of the following is likely to be decreased? Which of the following likely to be decreased? So actually, what is the diagnosis here? And regarding the diagnosis, you have to match the option. Here they are speaking about a 37-year-old woman and she is having an enlarged thyroid gland with an increase in level of your T4 and T3. If they are increased, then which would be decreased? Here we are speaking about a person who is having a hypothyroidism. So what would be here if the heart rate, cardiac output, peripheral vascular resistance, and the ventilation rate, what would be the main thing which is getting decreased? Which is getting decreased? All of them, especially your heart rate, cardiac output, your ventilation rate, even sometimes your renal blood flow, and sometimes here I hope everyone is getting confused yourself. Just because enlarged thyroid gland is given, it doesn't mean it's hypothyroidism. And you should see the plasma levels also if it is increased. Okay, so if it is increased, it shows hyperthyroidism. See, they are asking which levels are decreased. Your contractility of heart, even your RAS system, right? Even your filtration, that's your GFR, glomerular filtration rate, everything gets increased except your peripheral vascular resistance, that is going to be decreased. So this is one of the important exception that you have to remember. And also your BMR, I'm not going to write what happens in hypothyroidism. It is easily understood that is an exact opposite. Your basal metabolic rate gets increased. Your brain function will also get increased. That's the reason sometimes hypothyroidism people will have a mental confusion. Okay. Sometimes too much of CVS function will end up with heart failure. A person or a woman continuously under medication just withdraws the medication for about 5 to 6 months, faced a death suddenly, then that's the reason of your hyperthyroidism, in which your cardiovascular functioning is too much, ends up with high cardiac output causing heart failure. If I speak about GIT motility is also increased. Increased motility. So these are the few things in hyperthyroidism diagnosed patient in which they will be getting increased. Even their metabolism levels are also higher. Okay. And the person or a Patients will be looking so thin just because of their increased metabolism. The patient or a person will look will look so thin, and the reason they'll have a exophthalmos, exophthalmos. Okay, yeah. So this is a few. I would say diarrhea is obviously seen in hyperthyroidism. As such, your GIT motility is increased. Diarrhea is obviously seen in your hyperthyroidism. So these are the few features which would suppose you to diagnose whether the patient is in hyper or hypothyroidism. The next question, how would someone experience heart attack caused by a blood clot benefits that stimulates the conversion of plasminogen to plasmin? So here it's also a simple easy question in which if you remember your coagulation cascade or a pathway of clotting pathways, it's easy for you to remember. It causes growth of new vessels, oxygen carrying capacity of RBCs increased, plasmin inhibits formation of new blood clots, and it dissolves the fibrin meshwork around blood clots. Plasminogen to plasmin conversion. What is the answer here? So there is a blood clot in a person who is having heart attack. That we know already. There will be a thrombus formation, isn't it? And that's the reason the patient or a person is feeling a pain. After the clot forms, we feel there is a conversion of plasminogen to plasmin, which happens in your pathway also. And this results in very, very right. That is the dissolve of the fibrin meshwork around the clots. Once they start to dissolve, once there is a conversion of plasminogen to plasmin, this dissolve of fibrin meshwork around the blood clots cause this blood clot to be dissolved and causing the pain. This relates with your both pathways and the conversion from plasminogen to plasmin. Here the pathway should be clear. That's the reason we have given that question. I hope you all know about the extrinsic and the intrinsic pathway, isn't it? Extrinsic and intrinsic pathway is very important even in your pathological and your medicine. So please be very sure about these pathways. And please remember what are all the common pathway and what are all the involvement in your intrinsic and extrinsic pathway. I have given here, but still I'll mention what's the common pathway. Okay, your 10th factor, second factor first, your calcium, your platelets, and your fifth factor. This is all involved in your common pathways. And once the fibrin gets converted to clot, again this fibrin clot will form a clot retraction. Again, this will form a clot retraction. Apart from this, in all the pathways, the main thing you have to remember is their importance in the laboratory diagnosis. If I would say in intrinsic pathway, the factors that is involved are 12, 11, 9, and 8. There is a deficiency, or I could say these deficiency can cause increased level of which one? Activated partial thromboplastin time. Please remember the normal activated partial thromboplastin time is 25 to 39 seconds. They would be increased. In your extrinsic pathway, especially when your factor 7 and the tissue factor is involved, here if they are deficient, then they would lead to increased prothrombin time, which is about 15 to 20 seconds. So in the common pathway, if there is any deficiency, there is a common pathway, both your APTT, your activated partial thromboplastin time, and the prothrombin time will be increased. So this is some laboratory diagnosis which you have to remember in the pathways. You have to remember in the pathways. I hope it's clear for you, especially in hemophilia. When you speak about hemophilia, one of the important diseases or the abnormality which is involved in the pathway, here we can able to see APTT that is getting increased because hemophilia comes under your factor 8, especially, which is more dominant than a 9. If we say 8, 9, then hemophilia A and B comes in your intrinsic pathway. So that deficiency factor can increase the activated partial thromboplastin type. So please remember this pathway is also important. So this is an easy question. Yeah, that's right. It's an X-linked recessive disorder, which is a hemophilia A. A 2-year-old boy bleeds excessively from minor injuries and has previously having a bleeding gums. The maternal grandfather has a bleeding disorder. The child has physical examination, shows slight tenderness of his knee with fluid accumulation in the knee joint. Literally it shows arthralgia, and they have a bleeding disorder, right? So these are the hemorthrosis. If the patient or a person is having bleeding or any fluid accumulation in the knee joint, it's nothing but hemorthrosis, which a very unique feature of because of the factor A deficiency, that's your hemophilia A. It's a direct question, but still the nature of the question might be big. But still here, hemophilia shows the deficiency of factor A. Okay, because of the hemorthrosis and bleeding disorder of the grandfather in a maternal nature, which is given. Always remember, females will the carrier. Females will always be the carriers in hemophilia. And the sufferers are always male. Sufferers are always male. That's why they have said a maternal grandfather, mother's side grandfather, is having this bleeding disorder. And that would be the nature why the boy had been suffering from this hemophilia, which is a royal disease of factor 8 deficiency, which is hemophilia A. Yes, so hemophilia A, which is of clotting factor A deficiency, hemophilia B, that is factor 9 deficiency, hemophilia C, that is 11 deficiency. There is also parohemophilia, which is different from their nature, that is factor 5. Okay, there are many factors and the explanations are there, but still please remember in hemophilia, I said you already, APTT, you have to remember just because they are involved in your intrinsic pathway. So APTT would be increased. And what about your clotting time and bleeding time? Please remember, bleeding time would be normal and the clotting time would be increased. There's also the laboratory findings which is to be importantly noticed. The clotting time and the bleeding time is very important. Bleeding time will be normal. As such, there is no any problem in your platelets and there is a problem in your factors. That's the reason you have a clotting time level that is increased. Very, very important. Okay. Now, yeah, APTT will also be increased. Clotting time is also increased. Your prothrombin time will also be normal. Okay. Yes. So the next question, as such, we are running out of time. The next question is ligand-gated calcium channels are present in. Ligand-gated calcium channels are present in. This question comes in your skeletal muscle contraction. Important to remember about their excitation contraction coupling as well. That is very right. Ryanodine receptors. Then what about dihydropyridine receptors? What is the channels of dihydropyridine receptors? In the skeletal muscle contraction, yes, it's a voltage-gated calcium channels. So voltage-gated calcium channels. Whenever skeletal muscle contraction is there, it's a very fast recall for yourself. Action potential in neuron will be there. Once there is an action potential, then the skeletal muscle contraction causes the opening of dihydropyridine receptors. Once they are opened, then your ryanodine receptors are open and they will open your ligand-gated calcium channels. When this calcium is open, they will be coming from your sarcoplasmic reticulum. So SR, this denotes your sarcoplasmic reticulum. This calcium then binds with your troponin C. So that is how the contraction actually happens. Whenever they bind with your troponin C, then they have a shift of tropomyosin, isn't it? I hope you remember. There will be a shift of tropomyosin, then that is how they have this coupling of contraction, and the actin will move inward. Actin inward move will be there. So this is how contraction happens, and this is how you remember this ECC, that is excitation contraction coupling. So here the ryanodine receptors will be having a ligand gated calcium channels. So I have depicted you a very fast review about how the skeletal muscle contraction happens, which is actually depicted in the picture below. Now, the next question is, it's also an easy question, direct one-liner. Macrophages are examples of antibody secreting T lymphocytes, activated plasma cells, antigen presenting cells, or all of the above. So what is the answer here? Macrophages are an example of please remember, all of your antigen presenting cells are example of your macrophages. Not all of the above, all of your antigen presenting cells are example of your macrophages. So see, in the above part of contraction, please remember this also. It's also an important part which has been asked in your question, which I remember now. Remember the mnemonic ZIHA. ZIHA, I hope you remember. I've already taught you before. Z line comes closer in your contraction. I width decreases. I bandwidth decreases. And what about H? H band disappears. And what about A band? A band is a constant band. It's a mnemonic ZIHA. The reason I'm mentioning you here is once in a while they have asked this as an exceptional question. Remember, Z line comes closer, I band decreases, H band disappears, and A band is a constant band. So coming to this part, macrophages. Remember, all of your macrophages we have in all of our cells, but still antigen presenting cells are a good example of the below mentioned option. You have example of osteoclasts as your macrophage, Kupffer cells, your Hofbauer cells. Where is your Hofbauer cells? And you have epithelioid cells. All of them are macrophages. Epithelioid cells are present in your granulomas. And you have mesangial cells. The mesangial cells, which is in your renal, kidney, is the main important good example of macrophages. Can anyone mention Hofbauer cells are present in? Histiocytes, very right. Placenta. Histiocytes are macrophages in your lymph nodes. They are present in your lymph nodes. Your red pulp is a very good example of macrophages in your spleen. I hope you know about microglia in your nervous system, which is a macrophage. The nervous system. So many other macrophages are there, but still these are the very few important macrophages. Please remember, including that antigen presenting cells are an example of macrophage. So which of the following are not a phagocytes? Which of the following are not a phagocytes? Eosinophils, microglia, mast cells, and plasma cells. Which of the following is not a phagocyte? What's the answer here? So all of them play a very important good role regarding your function in all of the defense mechanism. whoever undergoes a defense mechanism can come in phagocytic function. It doesn't mean like phagocytosis process, which is done by the cell, undergoes phagocytes. Even your eosinophils undergo phagocytes. Even your microglia, which is a macrophage, that undergo phagocytes. Even though your mast cells are not a macrophage, but it's a mediator of inflammation that undergo by a defense mechanism, which is a phagocyte. But here plasma cells will never ever comes under a phagocyte, which is your B or a T lymphocytes or any kind of a T lymphocytes. Okay, so please remember, even your eosinophils are a defense mechanism. Increase it, they involve in your immune mechanism. The cells which is involved in your immune mechanism, which get deranged in the part and undergoes phagocytes, cytosis process, are considered as phagocytes. But here plasma cells doesn't undergo any of these, so it is not a phagocyte. So falls about the tract depicted in the image below. Actually, what is the tract that is shown here and which is false about the statement? Which is shown and which is false? Which is shown and which is false? The tract that is shown in the picture is, any idea? The tract that is shown in the picture is, remember here the tract is a pathway of, isn't it a lateral or anterolateral, or what kind of pathway that is shown here? Dorsal pathway. Dorsal, anterior, lateral. Yeah, that's right. It's the anterolateral pathway that is shown here. It's a lateral pathway that is shown here. That's an anterolateral pathway also, I could say. So, which is false, or here, which is false regarding the tract that is depicted here? Sorry, once again. So, once again, please see the picture and say me which is the tract that is shown in this pathway. See very clearly and say me what is the tract that is shown here. Is it a anterolateral pathway or is it a dorsal pathway? Are you sure? Is it an anterolateral or dorsal pathway? See very clearly and then you can answer the question. It's a very simple thing. Yeah, it's a dorsal pathway. Please remember, whenever there is in a spinal cord, for example, in a spinal cord, there is a crossover. Or if suppose in a spinal cord, there is no crossover and if there is a direct involvement of the impulses or the tracts are going. The crossover or in the spinal cord itself, it is an example of anterolateral pathway, and there is no crossover. It dorsally the tract goes upon. It is literally a dorsal pathway. So please understand this is your dorsal pathway. And now please answer this question, which is false regarding the tract that is depicted. Now answer me the question. So if you know what is the dorsal pathway and their functions, then you can mention here which is false regarding that. Yeah, very right. This is your crude touch. Please remember in your dorsal column pathway, see what is this tract? Please omit it. Some things or some alphabets are given in Chinese letters, but still omit it and please say me what is the pathway here, which is shown. Isn't it a dorsal column or anterolateral pathway? Yeah, it's a dorsal column tract. And please remember always, in a dorsal column tract, we have two tracts. One is your cuneatus tracts and another one is your gracilis tract. Another one is your gracilis tract, which involves in your upper and the lower limb. Upper and the lower limb. Always remember your 2-point discrimination. 2-point discrimination. Your vibration and fine touch. Your vibration and fine touch. Chinese dorsal tract. Yes. Your proprioception and your localized pressure. And your localized pressure that is involved in your dorsal column pathway. Okay. So these are the very important functions which you have to remember. We have a Bacillus cuneatus and Bacillus gracilis. And 4 of the important functions, that is 2-point discrimination, vibration and fine touch, proprioception and localized pressure. It's not a normal pressure, it's a localized pressure. And if they ask you nerve roots of cuneatus, cuneatus and gracilis nerve roots, please remember the nerve roots. Sometimes there is a possibility that they can ask you from the cervical root till the T1 to T6 roots. And here in nucleus gracilis, it is T7 to T12 lumbar and the sacral view is also involved. That's the reason upper limb is involved and here lower limb is involved. Okay. Yeah. So what is this tract that is given here? I said you the crossing over is inside the spinal cord. If the crossing over is inside the spinal cord, then this is your anterolateral tract. Isn't it? It's your anterolateral spinothalamic tract. So the crossing over is there. This is your first order neuron. The crossing over is your second order neuron. The neuron which is going to your thalamus is the third order neuron. Please remember the third order neuron, even in your dorsal column tract, also in your anterolateral spinothalamic tract, starts in your ventero-posterolateral and ventero-posteromedial nucleus of thalamus. Both of them starts in the same nucleus of thalamus. And what about their function? The functions of them are also very important. See the crude touch plus pressure. It could be any pressure. It could be a localized pressure. It could be any kind of a pressure. A tickling sensation, an itch, and a sensation, sexually sensations are also involved in your functions of anterolateral spinothalamic tract. Okay. They also involve the pain and temperature sensation. Pain and temperature part of sensation. So this is a few important functions to remember in dorsal and the anterolateral spinothalamic tract. All of your tracts have 3 neurons, first order, second order and third order neurons. Only one tract of sensation have 2 neurons, which is that. All of the tracts, like all sensation, crude touch, pressure, sexual sensations or any kind of a 2-point discrimination, proprioception sensations have 3 order neurons, that is first order, second order and third order neurons. Only one tract have 2 order of neurons. What is that? Any idea? Which sensation will only have 2 order of neurons? Which sensation will only have 2 order of neurons? Any guess? Any random guess? Any involvement of any kind of a sensation? Either it could be pressure or it could be a itch or it could be a tickling sensation. Now I'm speaking about the sensation. Which kind of a sensational function will have 2 order of neurons? It's a smell sensation. It's a smell sensation which have only two order of neurons, the first and the second order neurons. Okay. Yeah. Coming to the next question. All of the following are proprioceptors except. So if you know which are all the functions of proprioceptions, then it is easy for you unless it's a bit difficult. Answers or options are muscle spindle, joint capsule receptor, touch receptor, and Golgi tendon. Proprioceptors actually comes under your stretch receptors. They actually come under your stretch receptors. So all of them are under your somatosensory part. So all of the following except our proprioceptors, four of them. Muscle spindle, joint capsule, touch or Golgi tendon. Please remember your touch receptor always comes in the very right chetna. Your touch receptor is under tactile receptor. Very, very important. There are few touch receptors which is to be remembered. Please remember at least this. You're not going to remember everything. At least please remember this. In touch receptor, you have proprioceptors. You have tactile receptors. You have nociceptors. And you have hair cells. And you have hair cells. So in all of these, especially your muscle spindle, your Golgi tendon, and all of your joint capsule comes under proprioceptors. In your tactile receptors, your touch and the pressure, sometimes vibration also comes in tactile receptors. Nociceptor, a very important thing, that is your pain. Hair cell, that involves in your ear of cortex. Okay, so this is one of the important stretch receptor. Also, we call it as mechanoreceptors. Mechanoreceptors. Not going very in detail. So once again, I'm saying you, this is the phase. This is your about to be. We are about to touch our mid of April. You have May in your hands. That's it. This May should be full and full of your revision part. You're not going to study anything new. Within 20th to 25th April, you should complete everything studying new, even whatever the faculties or whichever revisions we are taking. Please, you can note down the important or the new points which you are getting before your end of April. All of the things which you are studying newly, please complete it. It's my humble request. Please don't study anything new after the first week of May. All the 4 weeks of May should be a revision. All the 4 weeks of May should be a revision. At least 3 revisions should be there. At least 3 revisions. So why we are keeping all these tests, all these revisions, all these chanting sessions, everything is a revision. Nothing else new should go into your mind in this May. Whatever you have read, either if you have done 10 pages or if you have done 100 pages, the 10 page you have studied should be very clear. You should be studying that 100%. Please don't get worried about the notes, about the content, about the pages which you have. If you study 5 pages, please study it by heart. That is very important. For example, in one day, you are making a schedule to study 3 subjects. Have a habit of studying by schedules. If you have 3 subjects to study, for example, if you make a schedule of studying, yeah, I could understand anxiety will be there even if you sleep, even if you go, even if you sit, even if you eat, but that should be under control. That will be better for your studies, I could suggest. So if in one day I am taking extra 5 minutes for just to give you a complete overview of how you wanted to manage the time, right? So apart from your studies, this is also important, that makes you in a proper way. So these are the mechanoreceptors. So please see, if you are making a schedule, try to follow the schedule. If you are getting means if you are skipping the schedules, that is perfectly fine, not a problem. Try to be in a consistent way. Consistency is very important. Remember the 3 R's: read, revise, and retain. How much you read is important, how much you revise is important, and how much you retain is also very, very important. But please make a habit of preparing schedules, then you start to study. When you start to study, everything is under control. No one is going to ask you rather than what you have studied. Everyone is going to ask you which is inside your text, which is inside your syllabus, until and unless which you answer very rightly. Okay. So as we are running out of time, please remember our basic main aim is to make everything correct, which is easy. The questions which is easy should never be wrong. That is important. Please leave about the difficult questions. I'm speaking about the easy questions which should never, never, never be wrong. Okay. Yeah. So please concentrate on that. Final 6 more questions. A man falls deep sleep with one arm under his head. He is unable to move his hands when he is awake. However, tingles and pain sensation is still intact. The reason for this loss of motor function without loss of pain sensation is that in the nerves. So what is important here? A fibers more sensitive to pressure than C fibers. Motor fibers are affected during sleep than than sensory fibers. C fibers are more sensitive to pressure than A fibers, or all of the above. So what is the answer here? Very right. That is, A fibers are more sensitive than C fibers. Very, very important and very right. So here there is a thing for pressure, for hypoxia, and for anesthesia. Means the sensation loss. You have to remember some things. For pressure, it is A fibers, which is more sensitive than B. B fibers, which are more sensitive C. This you have to remember. In hypoxia, B fibers, which are more sensitive than A, and A fibers, which are more sensitive than C. If suppose in the question, a man is sleeping with a deep arm under his head, if it is not speaking about pressure, if suppose the question is speaking about hypoxia, then your answer should be B more than A. In anesthetic function, the question will be A gamma will have more sensitivity than A delta, which is having even more sensitivity than A alpha and beta. Then comes your B and C. So this three should be very clear to answer the clinical questions of the sensitivity regards with pressure, hypoxia, and anesthesia. Right. So the next question, it's a 79-year-old man who is experiencing peripheral nerve damage of his lower right limb. What is the type of lesion? And mention one feature you will be seeing. This is the one feature you can see. If you're very clear about upper motor and lower motor lesion, it will be easy for you. If you are very clear about upper and lower motor lesions, it will be easy for you. How can you defer this? And what's the answer here? As such, it's speaking about peripheral nerve damage of his right limb. Right limb in a peripheral view always gives a lower motor neuron lesions with hypotonia, which here the nerve involvement, which is below your spinal cord level, that comes on with your lower motor neuron lesions. And they are having a damage in a peripheral part that the 79-year-old man experiencing is as hypotonia. Please see the differences of upper and lower motor neuron lesions. It's a tone, it's regarding your movement, and it's regarding your reflexes. If you're not going to remember everything, please remember something, that it is with your atrophy. Please remember there is no atrophy or there is prominent weakness in your lower motor neuron lesions, and there will be atrophy in your upper motor neuron lesions. And also we have fasciculations that are not there in your lower motor neuron paralysis, which is due to a anterior horn cell degenerations. This abnormal movement and the tone is very important. So there will not be any atrophies, there will be no fasciculations, tone will be increased, and reflex will be increased in your upper motor neuron lesions. In lower motor neuron paralysis, there will be atrophy, there will be hypotonia, and the reflexes will be less. Reflexes will be lesser. So these are the very four important unique natures of upper and lower motor neuron lesions. So this is also a very easy question. It's same from your notes. Erythropoiesis, when is your nucleus that is getting disappeared? At which stage it is disappeared? At which stage your nucleus gets disappeared? It's in your, please remember, your late normoblast is the stage where your nucleus get disappears. And if they ask you, HB appears first in, hemoglobin appears first, but they are not seen in stain. But they cannot be seen in staining. This stage is your pro-erythroblast stage. This also they have been asked. Please remember this. And which first appears in staining? If they ask you not appears in stain, that is of pro-erythroblast. First appears in stain, then that is of one thing, that is your intermediate normoblast. That's your intermediate normoblast. Then late normoblast, which we know already, that is nucleus get disappeared. Remember, then after your late normoblast, we have a reticulocytes, which is a remnant of RNA, which is a remnant part of RNA. Then we have our mature RBC, that's your erythrocyte, which is non-nucleated, non-membrane bound, and there is no mitochondria. It's an erythropoiesis process. Now, next question. A 49-year-old male experiences drooping in his left lower facial muscles below eye. Her forehead remains unaffected as shown in the image. What is the diagnosis? So what is the answer here? What is the diagnosis? Either it's a human lesion, element lesion, facial palsy, and none of the above. Please remember, this is a clue word here. His forehead remains unaffected. Means forehead, there is no wrinkle. It's one of the important term to be remembered. It's facial palsy. So what's the difference between your facial and Bell's palsy? Or else what is the actually mentioned lesion here? Either it's upper motor neuron lesion, lower motor neuron lesion, or what it is actually. And I'm getting multiple answers. So here, remember, always there is some differences between your upper and lower motor neuron lesions. See, here there is drooping of eyelids only in one part. In your lower motor neuron lesion, there will be unilateral paralysis of one side. And main thing is the patient or a person, it means the forehead will be not having any wrinkles. The forehead will not be having any wrinkles, and this is called as a Bell sign. This is called as a Bell sign. When the patient tries or a person tries to close the eye rolls upwards. The eye rolls upwards. When the patient or a person tries to close the eyes rolls upwards. This is called as a Bell sign, which is a literal thing in your lower motor neuron lesion. Okay. If I would say in a upper motor neuron lesion, there will be a bilateral paralysis. And one more important thing is they'll have a dribbling of saliva also. There will be bilateral innervation and bilateral origin of this lesion in upper motor neuron lesion that will be having some differences within them. And here in the question they have given left lower facial muscles below the eye is affected and the forehead is remaining unaffected. And the forehead is remaining unaffected. The Bell's palsy, the facial nerve palsy, all of them remains the same. No, Bell's sign and Bell's palsy will never be same. Bell's palsy comes under your facial nerve palsy along with some other signs and other infections, which includes your Ramsay-Hunt syndrome or some other source of infection that comes under lower motor neuron lesions. But the Bell's sign and the Bell's palsy will be different. They are having some source of the infection. Here, Bell's sign will be seen in your lower motor neuron lesion, where you will have upward rolling of your eyes when the patient tries to close the one eyelid. That's your Bell's sign in lower motor neuron lesion. But if you see in your Bell's palsy in the lower motor neuron lesion, it can be idiopathic. It can be idiopathic. It can be because of HIV infection. It can be because of varicella zoster infection. Or it can be because of herpes simplex virus infection, which literally we call it as a facial nerve palsy or a Ramsay-Hunt syndrome origin. If you see along with these symptoms and the lower motor neuron signs are also there, you could be able to diagnose them. That is the importance of this question, which I want you people to know the difference. Now, the decrease in phosphate reabsorption causes. Decrease in phosphate reabsorption causes. So what is the answer here? Decrease in phosphate reabsorption causes. Whenever phosphate reabsorption is there, whenever phosphate reabsorption is there, either of the two things can happen. So, what is the two possibilities when the phosphate reabsorption is about to take place? Two possibilities. One possibility of does it affect your calcium involvement or calcium absorption? How do you think? Does it involve or does it affect your calcium reabsorption? Plasma or calcium reabsorption is not involved in your calcium and the plasma calcium levels. Please remember, phosphate reabsorption always will be notified in urine levels, urine phosphate levels. They will increase your urine phosphate levels if the absorption is more. If the absorption is more, they will inhibit your alpha hydroxylase levels, and they will never ever involve with your calcium reabsorption, and they will not play any role in calcium absorption. They will not play any role in calcium absorption. So please remember, it's a direct question. If decreased phosphate reabsorption is there, if there is no or any other reabsorption that is decreased in urine, it may increase just because of your glomerular filtration. Just because of your renal filtration, your urine phosphate levels gets increased. That is nothing else to do with your calcium reabsorption. A female having iron deficiency anemia along with decrease in the level of T3 and T4, which increase in the level of TSH. What is the diagnosis? There is decrease in T3, T4 and increase in TSH. So what does this actually mean? Increase in T3, T4, the decrease in T3, T4 and increase in your TSH. Does it comes in hypo or hypothyroidism? Please remember, whenever your hypothyroidism comes into the picture, you have to think about two things. One is your T3, T4 and one is your TSH levels. If hypo and hyper are considered, we have to see about your TSH levels also. Here everything goes with Hashimoto's, endemic or Graves. You can be confused with anything. But what is the exact answer here? Here T3, T4 levels which goes on with hypo, that is your endemic goiter. See here, iron deficiency anemia is your clue. There is a dietary uptake of iron that is deficient. Dietary uptake of iron that is deficient, that gives you answer here of endemic goiter. If any autoimmune part deals with the question, or any antibodies against your thyroid cells, then it is your Hashimoto's thyroiditis. And if hyperthyroidism, it's literally with your T3 and T4 levels that is to be increased. Graves' disease also, which is before, which we have discussed. Next question is a young boy complaining of tiredness and shortness of breath who is diagnosed with anemia that shows microcytic and hypochromic anemia with normal count of WBC, platelets and shape of RBC. The shape of RBC is normal, WBC count is normal, platelets are normal, but the complaints are tiredness and shortness of breath is there. And they are saying he is under microcytic and hypochromic anemia. The good example of microcytic hypochromic anemia is, we know that already, that is iron deficiency anemia, but which is not in the option. What is the answer here? Aplastic, megaloblastic, sickle cell and the blood loss anemia. So if iron deficiency is there in the option, that goes on with your iron deficiency anemia. Here they have given tiredness and shortness of breath as a clue, but the counts are all normal. So here the answer is blood loss anemia. It never goes on with sickle cell anemia because the shapes are normal. It never goes on with megaloblastic anemia because nothing is mentioned with the vitamin B12 or folic acid. They have not mentioned anything about plasma cells or bone marrow. It doesn't comes under aplastic anemia also. See, this is the classification of macrocytic and microcytic and normocytic anemias. And these are the examples. In macrocytic anemia, the one and only good example is your vitamin B12 deficiency. In microcytic, as I've said you, we have thalassemia, but anemia of chronic diseases and iron deficiency anemia, we can consider in microcytic hypochromic. But the history of the patient doesn't shows anything. Here, if you see normocytic, normochromic, Even though they have mentioned microcytic, the shape and the count of RBCs are normal, we could go with anemia due to diseases, anemia of acute hemorrhage, and the aplastic or hemolytic anemias. See, as such here, no history is mentioned and everything is normal. Nothing of the anemias goes on with this. It's a kind of a rollout option that it is blood loss anemia. I hope it's clear, because aplastic, megaloblastic, and sickle cell have some unique other features. Even as such as he is a young boy, he could deal with any of the traumatic conditions or a blood loss condition which leads on with blood loss anemia. Right. The final question that it is shown in the picture from 1, 2, 3, what does it shows? From 1, 2, 3, what does it shows? Movement of sodium ions from outside to inside the cell. Movement of sodium from inside to outside the cell. And it's very easy. It's regarding an action potential of neurons. And movement of potassium ions from outside to inside the cells. It's very easy, and as such, it's your action potential, which regards with your neurons. If you say, or if you see ECF ion, which is your sodium that goes on from outside the cell to inside the cell, where your depolarization from RMP starts. So here the graph shows the action. Graph is nothing but your action potential of neuron, isn't it? Here in action potential of neuron, few things to be remembered, starting with your resting membrane potential. Then you have a depolarization. Then you have repolarization. You have after depolarization. And you have hyperpolarization. And you have hyperpolarization. So these are the few things regarding action potential of neuron that you have to keep in your mind. So resting membrane potential always regards with potassium efflux. Efflux in the sense potassium from inside goes outside. Depolarization, which is shown in the picture from 1 to 3. 1 to 3 obviously shows in between, that is here. Depolarization is there. That's what the reason we said movement of sodium ions from outside to inside, that is called as sodium influx. Sodium influx. Repolarization, after depolarization and hyperrepolarization, everything moves on with potassium efflux. Very simple. This is how the all over process of action potential in neuron happens. Please remember the graph of action potential in cardiac muscle. And please remember the action potential graph of SA node separately also. These three graphs are very important to remember. Okay. So these are the few questions that I would have that would make your revision very fast. So as such, we are running out of time. You should have your time for revisions as well. Please divide your day into 3. Don't read a single subject in whole day. Okay, don't read single subject in whole day. Just 5 minutes